Welcome back to the TinyDocs Talk podcast series, Pediatric Interview Edition, your guide in the clinical thinking station or clinical reasoning station of pediatric training interview in the UK. This is brought to you by the British Sudanese Association of Pediatric and Child Health, or BSAPCH in short. I'm your host, Isra Ibrahim, and joining us today is our presenter, Hanan Aliab. She will be providing a real life demonstration case of the clinical thinking station. So, without further ado, let's start our case.
Febrile Neutropenia. 6-year-old who will need to have ALL presented to you with fever and neutrophil count was 400. How you can deal with this case? So it seems I'm dealing with 4-year-old, right? 4-year-old who is known to have an ALL presented with a fever and neutrophil is 400. Um, this is a case of febrile neutropenia in a child with ALL. I will shift this patient to resus area, and then I will connect him to a cardiopulmonary monitor and give him oxygen via non-rebreathing mask, 100% oxygen via non-rebreathing mask, and attach him to pulse oximeter. I will I will escalate to my senior registrar or consultant and delegate the role to my team. I will start approaching this child with an ABCD approach. If the airway is patent, it's okay. If not patent, I will try to open the airway with head tilt chin maneuvers, and I will call the anesthetist if for intubation if the airway are at risk, for possible intubation if the airway at risk. I will assess the breathing, looking for the respiratory rate, respiratory effort, and sign of respiratory distress. I will listen to the chest for any added sound like crackles of pneumonia or any wheeze or any other added sound. Then I will assess the C. I will look for the blood pressure. How much is the child is hemodynamically stable or not stable? If the child is having low blood pressure, I will give him a bolus of 20 ml per kg of normal saline. Then I will assess the heart rate, pulse rate, and the capillary fill time, central and peripheral pulses, the color of the skin, looking for any mottled skin, any um, cold peripheries. I will also insert IV line, withdraw bloods for full blood count, inflammatory marker, liver function test, use and ease, and blood culture. I will also take lactate as well and VBG, or blood gas. I will then start an antibiotic. Is the child hemodynamically stable? Um, uh, I will start him on tazocine, and if the child currently on chemotherapy block, I will give him mirapiram in the first hour of presentation. I will also take other cultures, including urine cultures, and if necessarily, I will take culture from Bortacas or any other line. I will assess the D, looking for level of consciousness by AFBO, and I will see the pupil size, and I will check the blood glucose. I will examine the child, expose him, looking for skin rashes, non-blanching rash of sepsis, and mottled skin. I will also look for any other rashes and bruises. Then I will go to the family, updating them by each step which already done, and I will take a history, asking the family if the child is not having how many days of the duration of the fever, any previous MRSA colonization of the skin, and I will ask about the event which led to this neutropenia, like any other past history of upper respiratory tract infection, and what is the chemotherapy. I will ask about chemotherapy and how many blocks already he received, and is he on methotrexate block or not, and when the last follow up was. Then I will ask my team to bring the protocol of neutropenia if not done, so that I will follow the protocol of the trust of febrile neutropenia. Uh, I will then talk to the ICU to discuss the admission to ICU or or the work according to the policy and to stability of the patient. I will talk to the oncologist as well, updating him, and the microbiologist for the advice of antibiotic. I will proceed management. I proceed with the management of this patient, um, and then after admission, I will follow up the cultures. If the culture is negative after 48 hours, then I will discuss this issue with microbiologist. If the child is if the culture is negative and the child is not febrile anymore, and this child may be possible for discharge on oral antibiotic after discussion with the microbiologist and my consultant. If the culture after 48 hours are negative, but the child is still febrile, I will continue the antibiotic, and I will consider to consult the microbiologist, and most likely the blood culture will be repeated, and most likely the antibiotic will be shifted from tadocin to merovinum. After, if the child is febrile after 96 hours, then and all the culture is negative, then I will think of fungal infection. I will again discuss microbiology to start him on liposomal and fusaricin B um, with high suspicion of fungal infection. If the culture is negative from the start and the child is no more febrile, then this child could be for possible discharge with a follow-up. Usually in febrile neutropenia, we need to follow the protocol of antibiotic choice with the trust, and this is a multidisciplinary team. We need to liaise with the oncologist to update him, and also discuss with microbiologist the condition and the antibiotic choice. After the case, after the disposition of the case either to ICU or to ward, I will chat with my team for a debriefing session to see which went wrong, which things was good, to assess the performance and to improve the performance in next case of febrile neutropenia.
As we come to the end, I want to express my gratitude to our presenter Hanan Aliab for her valuable contribution. I'm your host Isra Ibrahim, and it has been a pleasure guiding you through this series. Remember, our platform here to serve you with more engaging content in training and pediatric medicine in general. Your feedback matter. Please don't hesitate to reach out and share your thought. Thank you for joining us today. Don't forget to explore the rest of BSAP CH YouTube channel, website, podcast for more information. Until next time, stay curious and keep learning.